A huge round of applause for all of our sponsors and everyone in the room. Now, ladies and gentlemen, I have a recognition. Some of you remember when I say I have a recognition, you all say recognize. I have a recognition. I want to recognize it's time for our first panel of the day, an amazing panel that will be talking on burnout in healthcare, breaking the cycle of exhaustion and neglect, which will bring together leading experts to discuss strategies, actionable insights, and practical approaches to supporting well-being, wellness, resilience, and long-term effectiveness across all of our healthcare systems. Please join me in welcoming our distinguished panelists, Victor Bycroft. He is Chief Nurse Executive at Humboldt County Memorial Hospital. Lieutenant General R. Scott Dingle, the 45th Surgeon General of the United States Army, CEO and founder of Dingle Enterprise LLC. Give it up for Colleen Fiamengo. Come on up. Colleen is an educator and healthcare consultant at Periop Nursing Consultants. Let's give it up for Dr. Jasmine Burns. Woo-hoo. Welcome. The founder and owner, CEO, and psychologist at Burns Virtual Psychological Solutions. Give it up for Sandra Sneed. Come on up, Sandra. Source Communicator, CEO, and founder of the Accelerated Self Program, and Dr. Barbara Hales. Come on up. The CEO and founder of the Medical Strategist LLC. Let's give them another warm round of applause and get ready for an engaging session. So I guess it starts with me. Am I set? Hello? Testing? Testing?
Go to the mic. It's better. You.
What tech?
Okay.
Oh, wait.
Yeah, they're trying, doing something. All right, so I'm using this mic. So hello, welcome everyone.
Picture.
We are going to talk about something that everyone in this room has either experienced or witnessed or is going through right now. Burnout in healthcare is not a new topic, but our conversation today is. Because today we're not just naming the problem, we're naming the systems, the decisions, the habits, and yes, the inner lives that either feed it or actually break the cycle of burnout. So let's begin. And our first conversation is going to be with Lieutenant General Dingle. General Dingle. You've overseen military medical systems at national scale, including the largest hospital merger in U.S. history and the Army's COVID response. You've managed burnout in combat. Start us at the top. What does burnout look like when it becomes a national security problem?
Okay, that's Sandra. Thank you for that question. Please excuse me. The military in me, makes me want to stand up, and I can't get that military out of me. But what does burnout look like when it becomes a national security problem? That's a great question, Sandra. As Sandra mentioned, I fortunately or unfortunately had the distinct pleasure of leading a very large hospital system, the military, both military and civilian. And with that comes a lot of stress. And so on one note, I could say that, man, I'm the living example of burnout and stress as a healthcare leader, having led in combat where my trauma teams went from trauma proficiency to trauma excellence to trauma fatigue. 3 to 5 trauma surgeries per day, over 500 to 1,000 per year of medical professionals conducting trauma surgeries in combat. Through COVID-19, where you all lived through the response of our healthcare system to the demands of a national or a global pandemic. But yet there is still only one healthcare force that is taking care of both the patients and themselves. And then finally, through post-combat operations, then my medical or military medical trauma teams then have what we call the Walker dip, where their trauma excellence has now dropped back down to trauma efficiency. And so at the national level, at the strategic level, what happens, you see 6 unique factors that happen through burnout in our nation. The first one is quality of care decline, a decline in the quality of care. When healthcare professionals become burnt out, it opens the door for mistakes. It opens the door for their acuity to get dull. It opens the door for the potential of adverse clinical actions in life, limb, and eyesight, endangering both mission success as well as the life of the patients. The second thing that you'll see at the national level is absenteeism in the workforce, which causes instability. Because of the healthcare force being overwhelmed, then we need days off too. And when that healthcare provider needs that day off, that absenteeism impacts the team. It destabilizes the workforce. And you know how we are as healthcare professionals. We are gluttons for punishment because you love to take care of people. You love to mitigate the illness, the sickness, the disease, the injury to make them well again. But we have to take care of ourselves so that we could take care of others. I'm reminded, I was talking to Sandra a second ago, of the stress of being the Army Surgeon General. And one particular time after a Pentagon White House press conference, and my boss had me to relay something that the President and the Secretary of Defense told us not to. He told me to say it. And Barbara Starr was grilling me on TV, and I'm like, oh my goodness, am I going to say it? Don't say it. So you got that dilemma. My boss said, say it. I said it. After I said it, the amount of stress, because now we say that, oh, Scotty, you're going to be on the Washington Post and the evening news tonight, don't be the one. And that stress hit me as I walked back to my office in the Pentagon. As I got back to the Pentagon, I closed my door and I almost passed out. I almost fainted. I realized that I had not eaten. I had not really been sleeping well for 365 days. We've been every day with the White House and the COVID task force. And the burnout hit hard. And it woke me up and said that, well, if I don't take care of myself, the absenteeism of the 45th Surgeon General is going to have irreparable second and third order consequences on the force. And I can't let that happen. Number 3, it's going to impact recruitment and training challenges. Because who wants to join a workforce that is already overworked, that is burnt out? And then who the professionals are transferring their experiences to the potential recruits. There are some that are driven by the goal and the objective to jump into the fire and help out, while others could be deterred. But recruitment and training challenges arise. Number 4 is mental health consequences. When providers deteriorate and the mental health is impacted, it leads to compassion fatigue. It can lead to emotional detachment and even suicide. The suicide ideations among healthcare professionals is already double the general population. Annually, 300 to 400 medical providers commit suicide. The burnout rates surged to 65% post-COVID. In my own headquarters in Arlington, Virginia, I had a senior professional, a colonel, jump from the 4th floor of our atrium in the midst of COVID. Burnout and stress. It's real because as you're trying to continue to take care of the people, that same provider, that same healthcare professional is trying to balance life at home. And those weights don't get easy. Then number 5 is systematic vulnerabilities and national resilience. A fatigued healthcare system that struggles to meet the demands creates bottlenecks and impacts our public health and safety. You saw when the COVID-19 pandemic overwhelmed our hospital systems. Well, our president then tasked the military to what? Provide 1,000 medical professionals to augment those hospitals. We had already deployed 5,000 Army medical professionals to support the national response to the pandemic. And the thing that people don't understand is that that same 5,000 and additional 1,000 military medical professionals were already working in military hospitals dealing with the same pandemic. So no rest for the weary, but yet we had to respond. Vulnerabilities in the system. And then finally, the national security concern. The health of a nation is inextricably linked to its healthcare system. If we are an unhealthy nation, you have an unhealthy military force, but you also have an unhealthy society that will struggle to exist through burnout. And so as the other panelists are going to talk, you're going to see each level from the strategic to the tactical. But regardless, it's going to take a combined, a joint effort of all to make sure that we are aligned with taking care of our medical professionals so that the system is investing into the wellness and the well-being, and that stakeholders at all levels are responsible for a supportive work environment with great leadership. Thank you.
Thank you, General Dingle. Clearly, that is a passion for the General, and you can understand why by the content that he delivered to us. So I'm sorry you have to follow that, Victor.
Yeah, thanks a lot.
Yeah. General Dingle obviously is speaking from the top of the system, the very top of the system. And you're inside it every day in small rural hospitals where the margin of error is razor thin. What does leadership accountability look like from where you sit?
Yes, I've been in hospitals for almost 30 years. I've been in leadership in hospitals for about 20 years, most of that in the small and rural. But all of that extends up into the larger hospitals and into the larger system. And what I have seen through all of this, as we look at burnout, as we see the challenges that we're facing, to me, it has all come down to a failure in leadership to meet the needs of our people. And the way that I have seen to combat that in my own practice, what I have tried to teach to my other leaders around me is the concept of extreme ownership. You might have heard that term before. But that basically means I'm going to take responsibility for everything within my sphere of influence. So if I am looking at a staff that is struggling because they don't have enough resources, they don't have enough people, there's too many patients, I first have to look at what have I done wrong with that? What can I do different to support that staff? I can't point the fingers. I can't go to them and say, you're not doing enough. I need more from you. I have to look at it and say, what do I do to support them, to give them those resources in some manner so that they are better able to achieve their jobs and still have that satisfaction with that job.
Outstanding. So you're taking personal ownership first.
Absolutely.
Is that how you do that? And then how do you transfer that personal ownership to the individuals in that sphere of influence?
You do that by being in their space. I could never lead from an office. You get too often from a staff. They get that ivory tower mentality. Administration is sitting up here completely disconnected. And I see in the hospitals, that's why we have an issue. That's why we have nurses. That's why we have others leaving the practice, is because they feel completely disenfranchised, completely disconnected. My practice has always been, I taught it to my staff, I taught it to my other leaders, I tried to teach it to other administration. Get out of your office. Meet those people where they live, where they work. See exactly what they're dealing with. Don't go by numbers. Don't go by your preconceived notions. Go out there and truly see and talk to those people. And when you get to a point that you can walk onto a unit and you see people smile and welcome you into that unit because they're happy to see you, because they know you are going to be there to listen, truly hear what they're doing, and help to solve their problems. That's when you start to pull them back in, make them feel like what they are doing is truly appreciated and that they are going to be heard, and you're going to help them to move forward.
Truly a small town response.
Absolutely.
And if we could bring that into a bigger context, what a great impact we could make on each of the individuals within our own sphere of influence.
Yes, because that can expand to any size institution.
Excellent, excellent. So, Colleen, Victor is talking about what leadership owes the workforce. And you've spent 40 years as that workforce. So tell us about shared governance and why it matters.
Okay, I'm going to follow the general's lead.
I hope it's not taller than you.
Well, I think petite was the word my mother taught me to say. I'm a perioperative nurse. I've always worked in the operating room. I love the operating room. For those of you who don't know what perioperative nursing is, it's care of the surgical patient along a continuum of care from when they enter in the preoperative phase, the intraoperative phase, and the postoperative phase. And let me start with what my 40-plus year career has taught me is, and it certainly mirrors one of the statements that the general made, is that education is a foundation building block of any civilized society who wants to keep its citizens safe and healthy. That's where I start. I'll get to the answer to your question when we first look at what's overlooked in healthcare and by the leaders, and that is an investment in maintaining, promoting, and developing education programs for their staff. And it's not just delivering the education, but it's creating a format whereby competency is determined and can be measured. This is something that the regulatory bodies look for. You have to be able to prove that your staff knows what they're supposed to know and they can do what they're supposed to do. That is what competency is. I have witnessed over 4 decades, I've lost count of whenever there's budget cuts to be had, the first thing to go is education and the educators who deliver that education. And then things spiral out of control for a bit, and everybody realizes that was not a good idea, and they bring it back. So we're reinventing the wheel, it seems like, every day. And what this tells me is that there's a low valuation of education in healthcare and a lack of understanding about the relationship between healthcare and the success of not just the workers, but the leaders and the organization as a whole. So again, it's that foundation building block that we need to pay attention to. What happens? Again, in mirroring things that have been said already, patient outcomes suffer. You get burnout. And then you see things whereby people get injured. What's interesting to me is if you look at most healthcare organizations' mission statement, what do they talk about? They talk about quality of care, they talk about patient safety, and they tell you that these are the things that make them great. And yet they're doing the very things to undermine their own mission statement, which has always boggled my mind. Equally confusing for me is the people making these decisions. They are highly educated people who have recognized in their career path they need to go to medical school. They need to get all the alphabet letters behind their name through education because these are the things that give them positions of decision making. It gives them autonomy. It gives them financial advancement. And so for themselves, they value it. And those are the same people that want their kids to get good grades so they can go to good schools, so they can be well educated to get good jobs.
Colleen,
yet,
I don't want to interrupt you, but there's something very significant in the work you're doing now. You're actually reviewing legal cases in negative patient outcomes. So where do you think burnout is affecting that, the negative patient outcomes you're seeing in legal cases?
Well, patients are being hurt. And when patients get hurt, nurses who feel responsible for that, I call that acute burnout. I've seen nurses, after I've reviewed cases, who leave their clinical practice in the operating room and even leave nursing as a profession. That's an acute response. It's called the second victim syndrome, and that's an immediate impact of burnout.
And so what role do you play in those legal cases that you're reviewing? You go even further into the actual courtroom, don't you?
I do. So as an expert witness, I review and look at how standards of care have been compromised. And the first place I tell any attorney I'm working for is to pull the education records, because that will tell you what health, so to speak, of that operating room exists. And I can tell you that 10 times out of 10, that's where their weak link is. They either don't have the documentation, they're using old tools, they'll review their policies and procedures, and they're still using standards that are 10 years old. I heard a statistic not long ago that said in this country, of all the surgeries that happen, every day, 11 people get something left inside them.
Mm-hmm.
If you're one of those 11 people, that's kind of scary. And I can tell you, just me, my little self, and I have reviewed 2 of those cases.
Wow. That's a huge consequence of burnout.
It is.
Do you have a conclusion? Bring it to
Yeah, so
Dr.
I think
Hales.
to answer your question about shared governance and what is that, because we can all talk about what the problem is, but what is a solution? So a solution that I have seen, work is implementing the model of shared governance. Nothing new, nothing that there's tons of literature about it that you can follow and look at. When you do that, you give people power. I read a thing the other day also that said, we are hardwired to want to have control. This is a human nature phenomenon. So shared governance is a model that can be implemented by leaders to give people power over their own work environment. It makes them own what they're doing, it makes them responsible for their workplace, and it gives them a sense of power over how things are being done. And then it takes away the blaming of, well, the manager's doing this, the director's doing this, it's their fault. No, it becomes your fault when you own it.
So I want to move now to Dr. Hales, because Colleen is naming what's missing in the institution. And Barbara, you're working with physicians who are burning out inside their own practice.
That's right.
So it's not just the hospital system, but the actual businesses that doctors have built. What's breaking?
Burnout. I think one of the biggest misconceptions of burnout is that physicians assume that they should be able to fix it. But it's not about strength or commitment. As physicians, we are trained to be resilient. We push forward. We treat everybody first. So when it happens to us, we think we must need to be more efficient. We have to work harder. We have to be able to control our stress. But the problem is that it's often a mismatch between the demands of a modern medical society and the doctors that work within it. It's a signal of misalignment, so that what the doctors are expecting is not what the medical care is demanding. And because of that, burnout exists. The fact is, until we acknowledge this misalignment, burnout is going to get worse. and more physicians are going to be affected among us.
So you have what you call a strategic practice blueprint, which does promise physicians that they can do less, earn more, and feel human again. So what's the first concrete thing a physician can change in their practice this week before any major structural overhaul?
Well, before that, the problem is different for each physician. So it's a question of identifying what the problem is for them. The first step is actually very simple, and yet is extremely crucial. And that is they have to understand where they are on the burnout spectrum and what got them there in the first place. Because burnout rarely happens overnight. It's a gradual process. So while they're working, it starts out just fatigue. And then it goes to frustration. And if this is not handled properly, it progresses on to disinterest in everything that was once meaningful to them. Over time, if it's not addressed, they are going to be either stuck or they're going to question what it is that they're doing and why they're even doing it anymore. What I see for physicians is most of them do not recognize how far they actually are into burnout. So before making any decisions, the most practical first step is clarity. That's exactly why I created something called the Burnout Reality Check. It's a very brief 2-minute self-assessment that will tell you not only where you are on the spectrum, but what it is that is demanded of you within your practice that's creating that situation. Because once you can identify it, you can then change it. The goal is not to wait until burnout itself makes the decision for you. Change things while you can before you reach that state. It's easy to understand where you are early enough that you still have the ability to shape what comes next. Remember, you don't have to leave the medicine that you love. You just need to change what doesn't work for you. It's about helping find a way to continue in a way that helps sustain you. I've had doctors come to me and say, for every 1 hour that I treat a patient, there's an additional 2 hours of charting that needs to be done. They're crying, I can never leave the office. I can't stop charting. I haven't spoken to my kids. I haven't had a meal with my family in months. I've had other doctors say to me, I can't make enough money to get ahead. I'm working harder, bringing more money in. It doesn't seem to make a difference. So what the problem is causing burnout can differ for each person. If this is something that you are experiencing, I made the burnout reality check easy for you to access. I have papers for you to access on a table in the back. And if not, you can go online to go.themedicalstrategist.com/burn-out. Even if you don't think that you have burnout, there are several different stages. And I urge you to take that so that you see just where you are in that spectrum.
That's good advice, Barbara. Thank you very much.
Thank you.
So, Dr. Hales has been redesigning the external practice, Jasmine, but I'm sorry, Dr. Burns, Jasmine Burns, um, but you're redesigning internal culture. So from within your own organization, tell us what that looks like.
So, oh, it's working. So I have received training and worked in various settings. VAs, schools, community mental health, all kinds of places. And I saw burnout in every setting that I worked in. And part of that was because we were made to feel like we were cogs in the machine. We didn't really get a lot of support from our leaders. We were told we had to hit a certain number, productivity hours, all of these things. And no one asked us, like, we had no say, no buy-in in these conversations that the leaders were having. I didn't like that, so I started my own private practice. I said, I'm gonna work for myself. So I now have a group practice. My lovely staff member is actually right here. And I told myself that I didn't want my staff to feel the way that I felt because I was experiencing burnout and I had just started in the field of psychology. So what I do is I have conversations with my team. I ask them, how are you guys feeling about your caseload? Are there is there any way that I can help you? A lot of people on my team were moms of kids under the age of 5. Y'all, we are tired all the time, and that's outside of work. So I model what I want my staff to do. So I will tell my team, hey, I had a hard night with the kids. I'm going to be starting my day a little later. You can still reach out to me. It just may take me some time to get back to you. I am very open in my communication. I am vulnerable with my team, and I'm transparent. By modeling that behavior, my staff now know, oh, okay, Dr. Burns is talking to us like that. We can do the same thing. And so we have a very strong, my team is small, we're about 10 people, but we have a very strong, safe relationship. And that helps with burnout, just knowing that there's like a safe work environment. And that goes a long way.
You've trained and practiced across the VA, private practice, schools, community mental health. You've watched burnout win in virtually every corner of the mental health field. And you've responded not with policy statements, but with action within your practice. Can you walk us through what boundary setting as a leadership practice actually looks like?
Yeah. So again, I'm really doing a lot of modeling, but I'm also educating my team. So one of the things that we're noticing, across healthcare, but I'm going to speak specifically to mental health and psychology because that's my field, there's a lot of systemic issues. So one of the issues that we're encountering a lot within my practice is reimbursement rates for insurance is abysmally low. And my team and I, we specialize in diagnostic evaluations, autism, ADHD, and things like that. And we are busy, and we see patients practically nationwide. We're about in 43 states right now. My practice is completely virtual because patient access to care is so important to me. So my little team, we're very, very busy. And it's very frustrating when we do all of this hard work. I kid you not, we've done like 5-6 hours of testing and we got paid out $144 from insurance. A lot of providers are just not wanting to accept insurance because of these low rates. We have providers who are accepting insurance, but because of these low rates, they're taking on all of these patients, as many as they can get, and they're burning out. So one of the other things that I do is, again, I talk to my team and I say, where are you now with your caseload? And where can we, like, what's kind of the realistic cap that you can do? And if they tell me a number that I think is too high, because I know they're doing other things, we calibrate. So having ongoing conversations is extremely important as a leader when you have, I don't care how small or big your team is, you have to have that ongoing conversation. And you have to notice those signs of burnout. If you have a staff member who is normally really on top of notes, they're happy and they're just kind of great at their job, and you start noticing things here and there, like they're making more mistakes, or you're noticing that they're not as happy or chipper as they used to be, they're quieter, things like that. Those are early signs of burnout, just some of many early signs of burnout. So as a leader, you have to tune into your team, just like Victor was saying. We're virtual. My team is spread out. I have team members in Texas and California, and yet I'm still present as I can be. And by catching those early signs and being proactive, that's a strong way that we can catch burnout.
And that leads to my next question. What's the gap between awareness and accountability?
I think leaders feel, I think, detached from their team. I think leaders become very busy in the big picture stuff, and that leads to not noticing what's going on, like in their home, so to speak, with their work, with their practice. And so, again, just like Victor said, we have to take that responsibility and that accountability as leaders, because there's a trickle down effect. It starts at the top. And if we're not taking care of ourselves, which often happens when you're leading something, again, we're not modeling that behavior. If we're overworking ourselves, our team, they may start overworking themselves. So we have to take an inward look. And I think that's where accountability starts, and that's where it's going to go a long way.
But you've also taken action.
I have.
Yeah, tell us a little bit about that.
So, in addition to the internal things that I'm doing within my practice, I also strongly believe in advocacy. I think that there are a lot of leaders of the nation, like our representatives, who are not aware of what we go through as healthcare providers, as even patients ourselves. And so I go to advocacy days. I've been to Washington, D.C., and I've sat down and I've spoken with federal representatives. If you don't know who your representatives are, Google. Who's my federal representative? Who's my local representative? You can use Google to figure out. And I went with a group of people, and we had these elevator pitches, because you have to be very concise when you have these meetings. And we talked about what the issue was. So for me personally, I was part of a LEND program, and that program was getting funding slashed. And this program is very important. We were learning a lot about autism and how to work with autistic individuals, empowering them. And there's kind of a shortage of that nationwide. So to have that funding slash was just not good. So anyway, so we went to DC, we had our elevator pitch, and we directly talked to the representatives and let them know the importance of the program. So if we can do more things like that as healthcare professionals and be that voice, not just for ourselves, but for our patients, that advocacy can go so far, because I just don't think the higher-ups fully understand what's happening.
Excellent. That's excellent.
So I want to turn it back to you, Sandra.
Thank you.
Yeah. So every voice on this panel today has named something real. We've talked about systems, leadership, education, practice design, culture, and all of this is true. But let's close with something that sits underneath all of that. Because in 12 years of working one-on-one with people in crisis, I'm just curious, do the outer fixes, these external fixes, truly hold until something shifts inside? Can you talk about that?
Yeah, what has to shift inside, the thing that is actually holding and grounding you, because just because you clear a bottleneck doesn't mean that there won't be another bottleneck. And it's you that's going through each of those bottlenecks, those stops. So what I've witnessed in thousands of soul readings are where I allow the universal consciousness to speak through me. And in soul readings, people have a dialogue with this consciousness. But I've noticed the shift that is occurring is coming from an ethereal place, just as burnout is. That is the curiosity of the mind, the soul, the spirit. These are the conditions of your being that determine your well-being. So it comes down to burnout isn't really something that happens because of external circumstances. It's because you're ignoring your spirit and your need for inspiration and recovery. And that it doesn't require policy change. Carl Jung called it individuation, where you are drawing closer to an authentic self. And William James called it stream of consciousness, which is an awareness beneath the noise. And universal consciousness, through me, calls it the accelerated self, where you're working within the aspects of your being that are the ethereal, that affect you even though it's within the unseen. It affects how you see the world every day, how you see yourself and your place in it every day. So I took this topic, burnout, to universal consciousness, the being I call God, to get their take. And I just want to read to you what they said. And I want you to think of this personally. This is a very personal message to each of you who are in healthcare. Here's what they said. The process that takes an individual from keeping up to losing ground is the first sign that trauma has occurred. Whether that trauma is caused by environmental influence or personal doesn't distinguish when you are treating trauma, because it is the individual's urgency to stop a wound that indicates the wound lives in you. Therefore, when the wound isn't healed in ourselves, the consistent and constant need to heal is an expression, external, instead of an internal impression. When that need to heal becomes an impression, when that need to heal becomes an impression, then there's a practice and a management of the self. Only in the practice and management of the self can we fully be present to the trauma in others. All right, I want you to join me in thanking our panelists, General Scott Dingle, Victor Bycroft, Colleen Fiamingo, Dr. Barbara Hales, and Dr. Jasmine Burns. My name is Sandra Sneed. Come visit my booth, get a soul reading, get contact information for each of these panelists if you think they can help. And remember, this conversation is just beginning. Thank you for joining us.